welcome all. Today's topic for the discussion is breast cancer and the pregnancy. Okay, so it is the GTG number 12 and it is a green top guideline. Most of the time this is asked from the SBA point of view. Okay, so what exactly about the breast cancer and pregnancy, how frequently it is, and which type of cancer is common, and what kind of treatment the patient is taking, and how it will affect the pregnancy, that all we are going to see here in this class today. So one thing you should remember, one sentence, that although pregnancy associated breast cancer often presents with more aggressive features such as high grade and estrogen receptor negativity, the tumor biology itself is not altered by the pregnancy. Therefore, management follows the standard oncological principles modified only by the gestational age and the fetal septum. Okay, so what exactly this means? The tumor biology itself is not changing. Whatever the tumor biology is there in non-pregnant state, the same tumor biology will be there in the pregnant state. Only thing is that it appears that the condition is worsened. It is mainly because in young patients, generally it is a high-grade tumor and they are estrogen receptor negative. So apparently it appears that it has got a aggressive feature. However, the tumor biology remains same. Say for example, it is the IDC, that is infiltrating duct carcinoma, which is which is commonest in the non-pregnant state. Same tumor biology will be there infiltrating ductal carcinoma even in the pregnant state. But it is because of the estrogen receptor negativity and the high grade of the tumor in young patients, it appears that the prognosis is worsened. However, the tumor biology is not altered. Okay, so therefore, what exactly the management is? The standard oncological principles, which will be modified only because of the gestational age and the fetal safety. These are the points which we need to learn. Okay, so this is what is the basic concept behind this. Okay, so the most common histopathological type of breast cancer in pregnancy is the invasive ductal carcinoma. Okay, so what are the key facts? Most common cancer in the women will be the breast cancer. Okay, lifetime risk is around 1 in 9 in UK. It is a leading cause of death in the age group of 35 to 54 years. Around 15% cases will be below 45 years of age, and around 5,000 women per year of reproductive age group will be having this particular cancer. During pregnancy, as I mentioned, how common it is? It is around 1.3 to 2.4 cases per 10,000 live births. Okay, per one of the commonest. Okay, but in pregnancy, it is around 1.5, 1.3 to 2.4 per 10,000. In women less than 30 years, around 10 to 20% associated with the pregnancy and postpartum. So among all the women who have the breast cancer who are less than 30 years, 20 to 20% will come with the pregnant state. Okay, so these are the patients which we will be managing. Okay. Now, when we are managing about the breast cancer, it is always the MDT approach. The management should involve the oncology, breast surgeon, obstetrician, and the breast care nurse. Okay, so breast care nurse is the key person here. Now, what is the key concept? That the pregnancy does not worsen the prognosis. Okay, that is the main thing here. But why prognosis may appear worse? It is mainly because these are the young age group patients, and in the young age group, you get a high grade tumor, estrogen receptor negative tumors, and there are increased chances of metastasis. That is why it appears that the prognosis is worsened. Okay. Now, what is our approach to the breast lump in the pregnancy? When you get the breast lump in pregnancy, we should refer these patients to the breast MDT. Again, this is a SBA, which you should remember. They may give you the scenario and the patient is having the breast lump. What is going to be your management? Immediate referral to the breast MDT. Okay. Now coming to the imaging. Now, what are the imaging? Which investigations are safe? That also we should know. Ultrasound. It is the first line investigation. It is the safe. So first line investigation will be ultrasound. It is safe during the pregnancy. Second, if the cancer is confirmed, then you go for mammography and we will use the fetal shielding. Third, MRI can be performed, but the gadolinium is to be avoided. Only if it is essential, then we will do the MRI. Okay, so ultrasound is safe. Mammography, if required, then using the fetal shielding, and MRI preferably avoided, especially the gadolinium, and it to be done only if it is essential. Then for tissue diagnosis, we can ultrasound guided core biopsy for histology is required. Cytology is unreliable because of the pregnancy changes. So what you go ahead is ultrasound guided core biopsy. Okay, so what exactly we look for in the biopsy? Basically, histology will be same as in non-pregnant state. We look for the grade, the estrogen progesterone state receptor status, so ERPR status and HER2 status. So these are the things which are important in the histology. Okay. Now, which investigations are to be avoided? CT scan to be avoided, bone scan is to be avoided, pelvic X-rays are to be avoided because of the risk of radiation. And other markers such as CA15-3, CEA, CA120, these will be misleading during the pregnancy. Okay, so what is safe is the first is the ultrasound. Okay, then for metastasis, what is the workup? Preferred will be the X-ray chest, liver ultrasound can be performed, and MRI. If there is a bone concern, then go for MRI. Okay. Then what is the management during the pregnancy? Should we continue the pregnancy? Should we terminate the pregnancy? Termination decision needs to be individualized. Okay. And that will depend upon the prognosis of the case, the treatment needs, and the fertility wishes of the patient. Then second is a surgery. Okay. If the surgery is required, what is the safe timing? It can be done in any trimester of the pregnancy. The patient can have breast conserving surgery or mastectomy. However, if the patient undergoes surgery, reconstruction is to be delayed. This is the one of the principle which is expected from the candidate. The surgery can be performed in any trimester. Okay. Mastectomy can also be performed. Conservative surgery can also be performed, but the reconstruction will be done uh, in the latter period, not in the pregnancy. Okay. Now, what about the auxiliary management? Okay. So for detection of the sentinel node, radioisotope can be used. Generally, they use technetium-99 and it is safe. However, blue dye is to be avoided. Okay. And if the node is positive, then go for auxiliary clearance. Okay. So for sentinel lymph node, radioisotope can be used, but blue dye is to be avoided. And what about the radiotherapy? Radiotherapy is contraindicated in pregnancy. We need to defer it until the postpartum period, except unless and until it is a life-saving or it is required for the organ preservation. Okay. Then what is the role of chemotherapy? Regarding chemotherapy also you should know, because sometimes they can ask the questions on this. First trimester chemotherapy is contraindicated. However, in the second and third trimester chemotherapy can be given. Okay. Now the which regimens are safe? These are the anthracycline based regimens are safe during pregnancy. For taxanes, there is a limited data. Okay, so anthracycline based regimens are safe in pregnancy. Then what is the key safety point? There is no increase in the miscarriage rate, fetal growth retardation, and long-term fetal harm with this. Okay, which drugs are contraindicated? Like tamoxifen is contraindicated, trastuzumab is contraindicated because that leads to the fetal toxicity, while tamoxifen is a teratogen. Okay. Now, supportive drugs such as antiemetics like 5-HT3 antagonist can be used, dexamethasone can be used, GCSF, guanosine colony stimulating factor can be used if there is a neutropenia. Okay. Then neoadjuvant chemotherapy is used for downstaging the tumor and facilitating the surgery. What is the timing of delivery? It is the term delivery. We'll go ahead with the term delivery. If early delivery is required, the corticosteroids are to be given. Generally, we have to stop the chemotherapy 2 to 3 weeks before the planned delivery. Okay, so this key principle also you should remember. Stop the chemotherapy 2 to 3 weeks prior to the anticipated date of the delivery. Okay, so during lactation, do not breastfeed if the patient is on chemotherapy, if the patient is on tamoxifen, or if the patient is on trastuzumab. Okay, so these are the contraindication for the breastfeeding. Patient on chemotherapy, on tamoxifen or on trastuzumab, if the patient is receiving, then breastfeeding is contraindicated. So generally, what is there? If there should be a gap of at least 14 days after stoppage of the chemotherapy. So that is why they have mentioned 2 to 3 weeks the chemotherapy should be stopped so that she can feed the baby after the delivery immediately. Okay. So if you stop it around 34, 35 weeks of gestation, then the delivery can be planned by around 37, 38 weeks of gestation, and then she can breastfeed the baby. Okay. then wait for 14 days after the last chemotherapy for breastfeeding. Okay, so what exactly can be performed? If she post-operatively also, post-delivery also she requires chemotherapy, then give short breastfeeding period. It is beneficial to the mother as well as baby, and then restart chemotherapy. And once you start the chemotherapy, you will have to stop the breastfeeding. Okay, so that is why it is always better to stop the chemotherapy 2 to 3 weeks prior, and the delivery will be planned 2 to 3 weeks after the stoppage of the chemotherapy. Then she can have a short period of breastfeeding and then restart the chemotherapy. And once the chemotherapy started, breastfeeding will be stopped. Okay. Now coming to the contraception after the breast cancer. Okay, so hormonal contraception is a WHO category 4. Okay, UKMS, here it is WHO category 4 they have mentioned, not the UKMSC they have given. The recommended is non-hormonal methods. What about the LNGIUS? Safety is not clear for LNGIUS. Possibly it will have benefit because most of these patients will be on tamoxifen, and you need to have anti-estrogen for this. So this tamoxifen, LNGIUS should protect the endometrium ideally, but the safety is not clear. Okay, so that is why caution is advised. Then future pregnancy after the breast cancer, MDT consultation is required. Patient should have completed the breast cancer treatment, and after 2 years the patient can conceive. So this also you should remember. After stoppage of the after complete treatment of the after complete treatment of the breast cancer, patient has to wait for 2 years. Okay. However, if the patient is on tamoxifen and patient wants to conceive, in that particular case, stop the tamoxifen at least 3 months before the conception. Okay, so tamoxifen should be stopped at least 3 months before the conception. Okay, if there is a metastatic disease, avoid the pregnancy. And impact of pregnancy on prognosis. Uh, uh, so basically, final message is that in pregnancy-associated breast cancer, sentinel lymph node biopsy using radioisotope is safe, while blue dye is to be avoided. Radiotherapy is contraindicated and deferred till postpartum. Chemotherapy is contraindicated in the first trimester, but can be safely given in the second and third trimester, with anthracyclines being the preferred agents. Okay, there is no adverse effect on the survival possible because of the healthy mother effect. So 5-year survival rate is around 92%. Pregnancy outcome generally reassuring. There is no increase in the congenital anomalies, no increase in the stillbirth, but there are possible risks such as the preterm birth, low birth weight. These are the possible risks. Okay. So management of the pregnancy after the breast cancer. Okay. So it should be a consultant-led care, and it should be in the multidisciplinary team. The cardiac monitoring will be required. 2D echo will be required if she has taken the prior anthracycline therapy. Generally, this is important from part 3 examination point of view, because there can be an OSCE station where the patient has received the anthracycline chemotherapy. So you have to say and get the cardiac 2D echo done. Then complication, there is increased cesarean section rate. There are increased delivery complication. Breastfeeding after treatment is safe from the unaffected breast. Only limitation is about radiotherapy, because radiotherapy will lead to the fibrosis and that will reduce the lactation. Okay. Then important point is breastfeeding does not increase the recurrence of the breast cancer. What about the fertility issues? There may be effect of the chemotherapy. Okay. Amenorrhea is seen around 20 to 70% of patients. Generally age factor, because the age, as the age increases, the fertility also reduces. And drugs like cyclophosphamide, these are the most toxic drugs. If you see the chemotherapeutic agent, among that cyclophosphamide is the highest gonadotoxic. Then you have anthracycline, which has got a lower gonadotoxicity, and taxanes have got the least. Okay, as far as the gonadotoxicity is concerned. Okay. Then hormonal therapy. Hormonal therapy, one is a tamoxifen, but the effect is that there is irregular cycles. GnRH analogs can be used that will give the reversible menopause, and another is a trastuzumab. There is no fertility effect. Okay. However, as we have seen that this tamoxifen and trastuzumab, they are contraindicated during the pregnancy. Okay. So key rule is that avoid pregnancy during tamoxifen, and wash up period of 2 to 3 months is required. Okay. Now coming to the fertility preservation. Okay, so the fertility preservation should be discussed early in all reproductive age group women with breast cancer, with prompt referral to a fertility specialist before starting gonotoxic treatment. So when we are starting gonotoxic treatment, we have to see the fertility aspect of the patient also, and we should offer them fertility preservation methods. Okay, so what are the fertility preservation methods for this patient? General principle is that early referral is essential, and it should be multidisciplinary team management along with a fertility specialist, especially when the patient is young and having the wishes for the fertility. Okay, so options, what options we have? One is to go ahead with the GnRH analogs. So what these GnRH analogs will do, they will reduce the ovarian damage. However, the evidence is limited. Second option available is embryo cryopreservation. Okay, it is most established. Success rate is more than 20%. However, it will be possible for the patients who have the partner. Okay, then second is a oocyte freezing. If there is no partner, then this is the option which is available. The patient can go for oocyte freezing. However, limited long-term data is available regarding this. And next option is a ovarian tissue storage, but it is an experimental stage only. The risk maybe because delay in chemotherapy and hyperestrogenic state. So when you go for these, say for example, embryo cryopreservation, the patient will have to undergo stimulation. That during that stimulation, you will not be able to give the chemotherapy. So there will be delay in starting the chemotherapy, and patient will be exposed to the hyperestrogenic state. Okay, so these are the risks in this. The other option is the assisted reproduction. Limitation is that reduced ovarian reserve post chemotherapy. The options available are the IVF, donor eggs, and surrogacy. Okay, so take home message that breast lump investigation, ultrasonography first. Cytology is not indicated. What is indicated is a core biopsy. Chemotherapy is not indicated in the first trimester or contraindicated in the first trimester, however safe in the second trimester. Radiotherapy can be given in the postpartum period only. Tamoxifen and trastuzumab cannot be given in the pregnancy. Delivery after 2 to 3 weeks after the chemotherapy. Breastfeeding cannot be given if the patient is taking chemotherapy or tamoxifen. Contraception, hormonal is contraindicated. Future pregnancy, patient has to wait for 2 years minimum. Fertility, cyclophosphamide is the most gonadotoxic. Then cryopreservation is one of the established treatment. Okay, so these are the things which you should remember from the GTG. There are certain questions are there on the GTG. Doctor, will you please go through these questions?
Yes, sir. A 32-year-old primary gravid at 18 weeks presents with palpable breast lump. Ultrasound suggests malignancy. What is the next best investigation to assess the extent of disease? A. MRI with gadolinium. B. CT chest and abdomen. C. Mammography with abdominal shielding. D. PET CT scan. E. Tumor markers. It is C. Mammography with abdominal shielding.
Okay, because we are suspecting malignancy here. Okay, so if there is a suspicion of malignancy, mammography we will have to do. Okay, but if there would have been an option for the core biopsy, that we would have selected that. Okay, so
Yes.
mammography with abdominal shielding, diagnosis imaging hierarchy will be USG first line. Once cancer is suspected, mammography is required with shielding. MRI gadolinium avoid unless essential. CT PET is contraindicated. Next.
A pregnant woman undergoes evaluation for breast lump. Which diagnostic method is preferred for definitive diagnosis? A. FNAC. B. Core needle biopsy under ultrasound guidance. C. Excisional biopsy under GA. D. Ductal level cytology. E. Tumor markers. It is B. Core needle biopsy under ultrasound guidance.
Yes, core needle biopsy under ultrasound guidance. Next. Explanation is that tissue diagnosis FNAC is unreliable. Okay, FNAC is unreliable due to pregnancy-induced proliferative changes. However, histology such as core biopsy is the gold standard. Next.
A 28-year-old woman is diagnosed with node positive breast cancer at 10 weeks gestation. What is the most appropriate management regarding chemotherapy? A. Start anthracycline chemotherapy immediately. B. Delay the chemotherapy until postpartum. C. Start chemotherapy after 12 to 14 weeks. D. Start taxane-based therapy immediately. E. Start trastuzumab. It is C to start the chemotherapy after 12 to 14 weeks of gestation.
Because it is contraindicated in the first trimester. Second and third trimester, it is safe. So start chemotherapy after 12 to 14 weeks of gestation. Chemotherapy timing is first trimester contraindicated, safe from second trimester onwards. Anthracyclines are preferred and trastuzumab is contraindicated.
Which drug is absolutely contraindicated during pregnancy in breast cancer? A. Doxorubicin, B. Cyclophosphamide, C. Paclitaxel, D. Trastuzumab, E. Ondansetron. It is D. Trastuzumab.
Yes, actually, I think others should also be contraindicated. I don't
Yes,
know, but
cyclophosphamide also.
cyclophosphamide is also contraindicated, so this is not much relevant. But among the breast cancers, trastuzumab, it causes oligodermness and fetal toxicity. Tamoxifen is also contraindicated. Next.
A 30-year-old woman at 22 weeks gestation has early breast cancer. She is suitable for breast conserving surgery. What is the correct approach? A. Delay the surgery until postpartum. B. Perform surgery only in third trimester. Proceed with surgery during pregnancy. Avoid surgery. Give chemotherapy only. E. Perform surgery with immediate reconstruction. It is C. Proceed with surgery during pregnancy.
Yes, yes. Because it can be see, perform surgery only in third trimester, not possible because surgery can be performed in any trimester. Okay, so
Yes.
proceed with surgery during pregnancy can be done. However, you cannot do the reconstruction. So
Reconstruction.
perform surgery at that time with immediate reconstruction. This option is wrong. Okay, avoid surgery. This option is also wrong. So this is the proceed with the surgery during pregnancy, but here they have not commented about anything about the reconstruction. So most suitable here is among these options, this is the most suitable. Okay. If there would have been any option, another option with a delayed reconstruction, that would have been the best. Okay. So proceed with surgery during pregnancy. Surgical management, surgery is safe in all trimester. Reconstruction is to be delayed. Radiotherapy is to be postponed. Okay. Next.
A pregnant woman is receiving chemotherapy for breast cancer. When planning delivery, what is the minimum safe interval after last chemotherapy cycle? A. 3 to 5 days, 7 days, 14 days, 2 to 3 weeks, 6 weeks. It is D. 2 to 3 weeks.
Yeah. We have to wait for 2 to 3 weeks. Timing of delivery and chemotherapy for the bone marrow recovery to prevent the neonatal neutropenia. Okay. Next.
A 34-year-old woman treated for early breast cancer asked about future pregnancy. What is the most appropriate advice? A. Pregnancy worsens the prognosis. B. Pregnancy should be avoided permanently. C. Pregnancy has no adverse effect on survival. D. Pregnancy increases the recurrence risk. E. Only allowed after menopause. C. Pregnancy has no adverse effect on survival.
Yes, pregnancy does not have any adverse effect on the survival. Okay, around 90-92% they have mentioned pregnancy has no adverse effect on survival. Post-treatment pregnancy advice, no worsening of the prognosis, may show healthy mother effect, but it is actually biased, safe after appropriate interval. Okay, so take home message: USG first, then mammography, then core biopsy is better than FNAC. If no chemo in the first trimester, chemotherapy is safer will be the anthracycline chemotherapy. Tamoxifen and trastuzumab contraindicated. Surgery safe anytime. Radiotherapy is deferred. Delivery 2 to 3 weeks after the last chemo, and pregnancy after breast cancer is safe. Okay, no worse prognosis. So that finishes this green top guideline on breast cancer and pregnancy. Thank you.